click on Learn with Us and look for Learning to Listen in the Conversations section. There's also a link there to our archive of Learning to Listen conversations over the years. To learn more about and register for more Brazelton Touchpoint Center conversations, events, and trainings, click on the link in the chat. To join the Brazelton Touchpoint Center's Learning Network, look for that link in the chat too. Thank you so much for joining us. Today, we will be learning with Dr. Scott Leibowitz, an international specialist in the care of transgender and gender diverse youth, who will share what he has learned from families and himself throughout his career and how those lessons can apply to each of us and our work. But first, a bit of information about today's Learning to Listen episode. More than 1,500 of us have registered for today's webinar, so please do feel free to tell us about you, where you're from, and what you do in the chat. Today, our superb interpreter, Maria Jose Gutierrez, joining us from Bogota, Colombia, will be simultaneously translating our webinar into Spanish. Thank you, Maria Jose. To access the translation, click on the interpretation icon in your Zoom controls, then select Spanish. To mute the English in the background, select Mute Original Audio. La conversación de hoy será en español e inglés. En los controles de su reunión, haga clic en Interpretación. Haga clic en el idioma que le gustaría escuchar. Para escuchar solo el español, haga clic en Silenciar audio original. To turn closed captioning on, just click on the closed caption icon in your Zoom controls and select Show Subtitle. You can adjust the size of the subtitles. And please use the chat feature if you have a comment to share or need help with a technical issue. Please put your questions for Dr. Leibowitz in the Q&A box. If you would like to receive a certificate of attendance for today's webinar, please be sure you complete the feedback survey. The survey will open in your web browser when this webinar ends. You'll also receive a link to the survey tomorrow in our thank you email to you. Before we begin, I want to thank our sponsor, the Burke Foundation, and our Brazelton Touchpoint Center production team, Nelson Artavia, Ryan Chevalier, Ashley Gaddis, Suzanne Okasik, and Michael Accardi. And now, I'd like to introduce today's guest, Dr. Scott Leibowitz. Dr. Leibowitz is a child and adolescent psychiatrist, author, speaker, educator, and consultant who is internationally known for specializing in the care of transgender and gender diverse youth and adolescents. He has been featured in the New York Times Magazine for his work as the co-lead author of the chapter on adolescence for the 8th edition of the World Professional Association for Transgender Health Standard of Care. Dr. Leibowitz has been a co-investigator in NIMH-funded research, has authored over 30 academic publications, and has edited 2 clinical guides on the subject. Dr. Leibowitz brings a wealth of clinical experience serving transgender diverse youth and their families, and has developed a reputation for his balanced approach to the ethical debates on adolescent decision-making. From 2008 until 2024, Dr. Leibowitz served in pediatric multidisciplinary gender clinics in 3 different pediatric hospitals in the United States. He spent 6 years at Boston Children's Hospital's Gender Management Service, the country's first such program in an academic medical center. Most recently, he spent 8 years as medical director of behavioral health for the Thrive Gender Program at Nationwide Children's Hospital, which has become the largest embedded therapy and assessment model of any pediatric gender clinic in the United States. He also has experience navigating clinical care through politically charged environments. Scott, thank you so much for joining us today.
Thank you so much, Dr. Sparrow. I would just want to say on a personal note, it's Boston Children's Hospital is where I trained. It's where I feel most at home, and I know you since those days as a fellow. So it's nice to be invited to this, and I'm going to now share my screen. Okay, let's do this. Okay, so thank you, Dr. Sparrow, and everybody for taking some time during your afternoon to meet and learn and hear an important conversation, one that's really relevant right now in society. And I'm going to just start with a disclaimer. The contents of this discussion or presentation contain information about gender care for youth and minors. The contents are for informational purposes only, not clinical guidance. And it's important to be aware of the local, state, country laws where you practice in order to understand the legalities of gender care there. And I'd be remiss to not say that it brings a degree of emotion to me to even have to include this disclaimer in my talk. I think right now, being a provider in this space comes with significant challenges and burdens. Ones where, in this era of anti-institutionalism and the attack of evidence and science, to be seen as an expert in this, and to have to even declare my expertise on this matter, is something that I'm not used to. I don't normally like to toot my own horn, but I kind of feel like I have to in order to say why I think I'm poised to have opinions on this issue that might be more informed and based on years of clinical experience. So let's just note that. And, I'll also note that providers like me are having difficulty giving presentations like this. And there might even be people on this webinar who are here for specific reasons to not necessarily learn, but just to listen to what I have to say or record a snippet of what I have to say. And I've had some of my talks taken out of context and put out there, and so I'm just doing this talk in that environment. Already elevates the level of fear, and it's something that I'm just putting out there transparently to be vulnerable with all of you. That I feel it's very important to share that, and that everything I have to say, I don't care if it gets published to the entire world. That being said, I do ask that you not take pictures or video of this presentation. Today, we're going to talk about my professional journey and like why I have an opinion and my outlook on it. Then we'll spend more time on the gender care for minors and their families and my take on how this all plays out now. We'll have hopefully a little bit of brief discussion and Q&A, and then at the end, I want to leave everybody with some future directions and a call to action. So starting with my professional journey. No talk on these issues should start without establishing some context about the person themselves. So let me just break down how I identify as a child and adolescent psychiatrist. I consider myself someone who is accepting of human diversity, an ally to the trans and gender diverse community, a compassionate and sensitive listener and healer, having 16 years of clinical experience serving over 1,000 trans youth and families in 3 different programs. Thank you, Dr. Sparrow. I consider myself an advocate, not an activist. I am against unnecessary barriers to care. I am in favor of appropriate guardrails, especially with kids. I believe in shared decision-making. I believe that adolescents have different decision-making abilities than adults do. I'm supportive of educating those who are willing to be taught. I'm also open to my own learning and self-improvement. I'm against politicizing gender care, and I'm passionate about standing up for the right thing. My career and that what informs my opinion is based on 16 years in 3 programs. The first was at Boston Children's Hospital, as Dr. Sparrow mentioned. It was the first multidisciplinary gender clinic in the United States. And back then in 2008, when I was a child and adolescent psychiatry fellow, they modeled the clinical approach. It was founded by colleagues Dr. Spack and Dr. Edwards-Leeper, and they modeled their clinic based on how the Amsterdam clinic was providing its care, which was very, very focused on assessment of young people. And you can imagine that being one of the first clinics, that it was really important to get it right. I subsequently moved to Chicago in 2014, and for just shy of 3 years, I worked in the Lurie Children's Hospital clinic and learned very much about the importance of access to care. that sometimes when you have a significant assessment approach, one that can take a lot of time and a lot of effort and a lot of resources, that is when wait lists grow. And the importance of getting people timely care is crucial, particularly given some time sensitive treatments that fall into gender care for minors. But the last 8 years, I moved to Columbus, Ohio, and felt that it was really important to develop a clinic and service that focused on both access and assessment simultaneously, as hard as that may be in this culture where mental health services are not reimbursed well, and many academic centers don't expand the behavioral health services for all kids, let alone trans and gender diverse kids. Sadly, despite us having built a very extensive therapy and assessment service, it had fallen victim to political attack, and there was a law that passed to ban the care here in Ohio in 2024. And I'm going to start with a sad story about the political unraveling of our service in Ohio. So this gives some insight into what we as providers have been dealing with. In November of 2021, the first gender care ban bill was introduced into the Ohio legislature. And then for 26 months before the law passed, we dealt with a practice environment that with unpredictable threat of the bill passing. So that lack of knowledge about will the bill pass, will it not? That included 9 proponent hearings in favor of the bill, which each time there was a proponent hearing, you would have higher acuity in the caseload. So our team would have to be managing all of the calls that come in and all of the extra emotional challenges that these hearings created for the families. We had 6 opponent hearings, so of course to advocate to not move forward with the bill, but those also bring up emotions. And what's really interesting is that each family reacts to the uncertainty in a different way. So you'll have one family that is ready to move before the bill even passes. Then you have other family that is willing to just stick it out because feel that they don't want any law to have to change their entire life and uproot them from where their home is here in Ohio. You have some families where you have different parents on different pages, different siblings on different pages with different priorities. And so this practice environment where we're navigating these issues before a bill even passes for 26 months takes a toll on us as clinicians and on the families themselves. In November 2023, the second version of the bill did pass both chambers with the introduction of a grandparent clause, meaning kids who were on treatment at the time the bill goes into effect could remain on treatment. They would not be able to get new treatments. So if you were on a blocker, you would not be able to get a hormone, or if you were not on any treatment, you would not be able to start any other treatment. And the bill also limited us from being able to refer patients to other states, and we would need permission, consent from a parent in order to diagnose gender dysphoria. A positive note in this story is in December of 2023, our governor, Governor DeWine, vetoed the bill from his own party. And myself, along with some of my colleagues, can be credited for that. I spent 3 hours with Governor DeWine, one with families, introducing him to 2 families so that he can meet these families for themselves. And he learned to listen to those families. And then 2 hours without the families talking about the science and the approach. And it's considered a feather in our hat, definitely, that he voted or that he vetoed the bill. Sadly, it was not the same priority that the legislature here in Ohio had. And a month later, they held an emergency session to override the veto. I have to say that at each of these hearings, it's so sad watching families beg the legislature, beg people for their lives to remain intact and not have to put them into this horrible position to be choosing between 2 kids or between 2 states. And to see those begging families have their voices go unheard and unheeded and not not listened to at all, really puts this squarely into like a political environment, and that's really hard to watch. Then for 8 months, we practiced under an environment where we weren't sure when the law would go into effect. And court delays and a trial by ACLU led to continuing to push back the date that the law went into effect. And what I should say is that era was very different than the practice environment with the unpredictable threat of the bill passing. Rather, we were practicing in an environment where families had to make a decision by a certain unknown date. And that's not really the way that we practice in medicine. These are decisions that often take time, and we in helping families make these decisions had to protect the integrity of the decision making process by ensuring that they weren't reacting to the idea that their rights were being taken away alone, rather that they were making this decision because it was the right decision to make. And that was an 8-month period. And then since August 2024, practitioners here in Ohio have been practicing with the law in effect after a judge sided with the state of Ohio. Even despite an appeals court has provided an injunction against the ban, but the ban is essentially still in effect, and wait lists have dwindled, research recruitment has dropped, and new patients can't access new care, and it's a whole different playing game. I want to start by saying a discussion about the complexities and ethical debates on gender care can only seriously take place, though, when both parties agree on the following: that gender identity is a real and valid concept that is distinct from assigned sex. Variations in alignment between the two are not inherently rooted in delusion. And often correcting the alignment with evidence-based medicine can improve people's lives. And I really feel that this statement is an equalizer statement to ensure that when you're having a discussion about gender-related issues, that you're on the same page with someone moving forward. Because for any subsequent issue that comes up, whether it's about locker rooms and bathrooms or pronouns and hormones, if there isn't agreement on this fundamental reality, one cannot be effective with any of the other nuanced arguments or complexities. And I think that that is what makes this a very important paragraph to absorb. So now I'm just going to talk more about the gender care with youth and their families and give you more perspective. So gender diversity is a natural variation of the human experience. And in the past decade, trans and gender diverse adolescents have been increasingly presenting for care at gender clinics across the country. And the clinical demand and the complexity has outpaced the research advancements, which makes this an interesting and complex field to work in. The big question: are adolescents too young to make permanent decisions? And I think at the root of this lie 5 overarching ethical debates that we see playing out. In childhood specifically, the debate is over whether or not social gender transition, so using a name, a pronoun, or adopting one's gender identity in a different setting alone, through dress or play or name, that alone, people have debated whether or not that is an appropriate intervention or mechanism to help someone feel better, both short term and long term, not medically. Then in adolescence, the debates are a little bit more expansive. There are debates around puberty suppression, and I'm not here to get into all of that. I'm just here to tell you about the overarching viewpoint. There are also debates around decision-making for more irreversible treatments and whether adolescents can or cannot make those decisions. Then there's debates over the degree of assessment and diagnostic clarity for gender dysphoria and whether gender dysphoria should even be in the DSM. And so this is really important because what are we assessing? And then there are the last debate, as I see it, is the timing of treatment as it relates to psychiatric or mental health conditions that a young person might have. And that depends on in what order do you do things. So whenever we have ethical debates, it's important to keep a perspective open. And I'm going to walk you through this diagram on several of these debates and what people are saying, really to illustrate that the truth lies somewhere in the middle. For those who are looking at the left wall and see an orange circle with a dark square shadow, and they say, that's what I see, they would be correct. This is true. And for those who are looking at the right wall and see a round blue circle with a darker circular shadow, and they say, well, that's what I see, that's they would be true as well. But the challenge is that the truth lies somewhere in the middle, and you need to take a step back and have multiple opinions on something in order to get the entire truth. It's when people have absolute narratives about what they see where we get into trouble. And I think that's really an important point to make, because now in the year 2025, we have a heterogeneous group of youth seeking care who really fall into three main categories if we look at it. So from a decision-making maturity variation standpoint, how mature is the adolescent when they're approaching life-changing decisions? You have some adolescents who are extremely well equipped to make important decisions and have made important decisions, no matter what their age. And you have other adolescents and even some non-adolescents who are older who don't approach decision making with maturity. Then you have variations in gender dimensionality, so gender identity, gender expression, and do the adolescents' treatment requests meet their core gender needs? And what is the function of gender for a young person? Is it the same for everybody or not? And I'll elaborate a little bit more on that. And then you have a range of psychological and psychiatric profiles, different personality types, and what's the relationship between the adolescent's gender and their mental health. Some people have mental health issues that are the direct result of unaddressed gender diverse or gender dysphoria, and others have distinct mental health issues that are not necessarily related to their gender dysphoria, but might be impacting their identity stability or their ability to make decisions appropriately. So what is the relationship between that? You can see there's an infinite amount of variations of those three different domains for any given young person in their family. And I didn't even address language and culture and ethnicity and race, and through the lens that many people's gender experiences are experienced by. So trans and gender diverse youth and families are not a uniform group. They have individual needs. They each go to different schools, are in different communities. They have different religions. They have different political ideologies and different political approaches. They have different family makeups. It's all important when it comes to understanding the person at the center of the treatment relationship. I have found that time informs high stakes decisions. And if we break down the groups of young people coming our way into two overarching groups, there are those who are presenting since childhood, typically easier for parents to wrap their head around, typically more binary in their presentation. And often these are kids who are not experiencing the world yet to influence their own expression of identity. And so I have found that uh, working with the young people whose experiences are extremely solid and stable for a very long time, in some ways has been easier, as opposed to those where this is an experience that comes for them in adolescence. Now, in that group, there's diversity as well. There might be some who are suppressing this experience since childhood, and adolescence or puberty awakens it. For others, this might be something that comes about as their bodies start to change. Um, it's harder for parents to wrap their heads around these young people if they don't have that childhood history. And that means that we have to do more disentangling in a mental health setting, especially for young people when they aren't always as binary in their presentation. What does that mean for people? It can be confusing. What's difficult is that discussing mental health challenges and diagnoses and gender diversity at the same time is difficult because transgender people have been and continue to be invalidated and erased, with their identities being described as delusional. And that's why the idea that a particular mental health issue or psychopathology would lead a young person to identify as trans is a very touchy and difficult subject. When an entire group of people's identity is being invalidated and called psychotic, then how can you possibly, uh, you know, explore these issues in their entirety? It could be very difficult. But that's why we have this multiple perspectives on the matter. And now, for those of you who are familiar with DBT or dialectical behavioral therapy, I'm going to do a little bit of DBT with you and show you the different dialecticals, meaning the two polarized opinions, where there might be some truth or partial truth in the middle for any given child or adolescent. So you have some that would say these are just vulnerable teens searching for identity. And others would say on the other side, stigma causes all the mental health issues and can lead to suicide. Aspects of both might be true, or there might be aspects of other things might be true, but the truth really does lie somewhere in the middle. Some would say minors are too young to make permanent decisions. Others say respect what the teen says. They all know who they are. And like I said earlier, some teens know who they are very well, and some minors are too young to make permanent decisions. You have the patient perspective, which is I know my body, I know what I need. And then you have the doctor perspective of I need to understand before I can prescribe. And again, bridging these perspectives helps us appreciate that the truth lies somewhere in the middle. There are those that say they're all going to regret it in detransition because they might have met one person or a few people who have. And then you have others whose transitions have been life-saving for them, and they will say regret is rare and detransition only happens as a result of stigma, when the truth lies somewhere in the middle. This is complex. For given different people, it could be different reasons. You have some that say they need to be fully stable before they can move forward with any permanent decision. Well, I don't know who's fully stable. I for sure cannot claim to be fully stable at any point in my life. And then you have others that say, well, the mental health problems will go away with treatment. And I would argue they don't always go away. And sometimes that doesn't mean that treatment shouldn't happen. It just means that other people might have other mental health issues that might be uncovered as a result of their transition, and that their transition is what led them to even be able to experience those other mental health issues. But like I would say here, the truth lies somewhere in the middle. So it's not that we assess a young person's gender. That's a self-experience and a self-actualization. Rather, I do believe it is our job as clinicians to assess how well a young person knows themselves and how well gender integrates into their identity development before they make a permanent decision. And just to show, gender can be very complex, and we need to be able to talk about these issues in a very complex way. For some, gender is a core identity. For others, it's a form of cultural expression. It might be a form of like autonomy in adolescence, of like, this is who I am, so I need to share that with people and be respected for it and test the waters. Or a way of attaining nurturance from others, or just simple exploration. And guess what? It's not just one thing per se for any one kid. It's not an either or. It's often a both and. The key is ensuring that this is a core identity issue for that person if that's what the treatment they're seeking is meant to address. The ultimate debate that we see now are those that argue ban the care completely. And then on the other side, there are those who say take away guardrails, like get access to everybody who wants and says they need it. And the challenge with this debate, different from the others, is that There is no middle. Those who want to ban the care don't even give any validity or notion that there is a reason to move forward with affirming a young person's identity. And those who want to eliminate guardrails can't understand or appreciate necessarily why there need to be guardrails, and that we do need to sometimes take a very pragmatic and cautious approach when it's indicated. My point is that this should be a discussion about how to do the care and not about whether to do the care. And that's where multidisciplinary approach matters so much. More perspectives means more improved ability to weigh ethical principles in the absence of strong longitudinal studies or evidence. The field itself is in its own adolescence, and so to expect that there would be decades-long research that would guide these decisions, that's unreasonable, and it's a double standard. It's also important to note that the evidence that we do have for the benefits of gender care with youth come from programs that have multidisciplinary involvement. And multidisciplinary teams are not always in abundance, so there's variations in resources geographically. But a key concept that I think is emerging more and more from the University of Minnesota's Institute for Sexual and Gender Health, Dr. Berg, Diane Berg, a psychologist there, and her teammates have really coined the term gender literacy, which is about developing awareness and skill sets to critically think about socially constructed and embedded gender narratives, and then being able to discern one's own belief and values from that. Let me break that down. That's a little complex. It means having an awareness that gender stereotypes exist, having the ability to understand that those stereotypes are external to the adolescent and child as their identity develops, having a developmentally appropriate awareness when the stereotypes are being reinforced by society, having an internal sense of pushing back against the conforming to societal rules when they don't feel natural, and being aware of what might happen in different situations when pushing back. And so one might argue that having gender literacy is extremely important before making big decisions that might have irreversible consequences. What does this look like across development? Well, for young children, it's the kids that have an awareness that there are girl things and boy things, and that these are just rules that don't necessarily apply to everyone. So a child who is gender literate would see a commercial that's reinforcing a stereotype and be able to say, that commercial doesn't include boys or girls, and it should, because boys can play with a certain doll as well. Whereas other children might not have gender literacy, and that doesn't make them illiterate, but what it makes them is that they're just not aware of the stereotypes being reinforced. In a school-age child, as they get older and develop more concrete thought processes, it's that child that knows that a boy wearing a dress might draw looks and unwanted attention, but not allowing that to impact their self-esteem because they've been taught and they understand, okay, this, I can wear a dress and still be a boy. And yes, the world might not always appreciate me for it, but this is what feels right for me. And maybe being able to modulate in different environments, more so out of protection and safety as opposed to what's right or wrong. And then in an adolescent, a gender literate adolescent would have an awareness, as an example, that sexism creates expectations on women and men, driving their behavior and ability to express emotions or feelings in a healthy way. Some adolescents have that awareness and others don't. And so our goal in a setting that helps families and young people who are trans and gender diverse, regardless of what they can access medically, is to develop this sense of gender literacy. So with that, I am going to take a moment for discussion and see if there are any questions in the chat. We have about 10 minutes to do so.
There's a really interesting question, Scott. Thank you. Here it is. Can you share more about how you determine someone is coming from a mature decision-making perspective the concept of maturity seems very subjective. Seems like an important question to ask you to address.
It is subjective. So I'll give you an example. There is no blood test to determine maturity level for a given person. So that is a very good question. And I think that it's not always one person's decision, over this is a person who's mature and this isn't. That's why this is a family-based approach, and learning to work with parents and families on how they see their kids is absolutely crucial. So an adolescent, for example, that might be able to have a conversation about something that they don't think will happen to them, but realize that that can happen to someone else, is what I would call a more mature adolescent than an adolescent who dismisses outright the idea that something foreign to them, that won't happen. So let's take the issue of regret. Talking about regret is such an interesting component of this work, because I think many people don't want to bring it up. It implies in some way that we don't believe you. I don't know who you are. You're probably going to regret it. So talking about that inherently is icky for a lot of adolescents. But I think talking about regret is important because we need to understand if the adolescent can at least appreciate the concept of irreversibility, and what what how they would manage something in the event that they did regret it. If we're talking about treatments that impact them for the duration of their life, uh, we want to have conversations with them and say, what do you think about people who have had these stories? What makes you different from them? Can you imagine that you may or may not share some of those the same types of stories? Talking to parents about how does the adolescent make decisions is really important. So when parents come into our office and on visit 1 or 2, they're telling me that their kid is extremely impulsive, and this exists way beyond gender. Even if gender is something that for that adolescent is a rather core experience of self, the parents are giving me the impression that they don't think their young person is ready. They feel their young person is making impulsive decisions. And so that's something that we want to work through and talk through. You could also bring this question up. Another example would be fertility. So a young person saying, I don't want kids. I'm never going to want kids again, which is something we have to talk about with them. Well, that's different than a kid saying, I don't want kids now, but I realize I'm a teenager, and maybe when I'm older, my life priorities might change, right? There's nothing wrong with either narrative, but the first kid is very fixated on what that kid thinks will be, as opposed to the second who has the capability of thinking outside of themselves. And I think that those are two examples of what I would say makes distinguishes a mature adolescent and decision maker from a less mature decision maker.
There's another question that I think is also really important to make time for, Scott. And It's, do you have any advice on how to work with parents who are struggling with their child's gender identity? Common challenge in this context. Research shows that family acceptance and support improves mental health outcomes for transgender youth. And you and I both are aware of Caitlin Ryan's research with regard to lesbian and gay adolescents and the importance of family acceptance for their mental health and well-being. So what's your advice for how to work with parents who are struggling?
This is an excellent question. I think it's come up almost every talk I give for 15 years, and it speaks to the dilemma people have in trying to engage different types of parents and families out there. Um, First of all, my number one opinion is really to meet people where they're at, because if they're coming in and seeing you as someone with an agenda, uh, then they are automatically going to have their guard up. So, step one, meet people where they're at. Step two, separate family members, because often if you meet with all of them together, or if you only meet with the adolescent and then you just talk to the parents as though you're an expert on their kid without you speaking to them privately, they're going to probably dismiss you as well. And it doesn't give people the feeling of safety that their perspective is going to be heard. Um, Adolescents and kids might have different perspectives on a certain matter. So an adolescent would say, I've been experiencing this my whole entire life. And parents might come in and say, I was there through the childhood years. I was there through their latency age years, and they were a happy kid, happy in their and seemed comfortable in their shoes, and there was no indication that they were struggling with any form of an identity exploration. And so that's where a lot of this is family-based work, and I would want to really sit down and validate that parent, and also validate where they're at when it comes to how they see their young person, and work step by step with them. So I think just meeting people where they're at, giving them the space to share things privately with you, and also taking a very neutral approach, and not coming at this work with like, my goal is for this treatment. Rather, my goal, which is the same goal as you as a parent, is for your kid to have an authentic, healthy, and happy life. And we just have to figure out together how and why and when we're going to achieve that. And typically, I think I've engaged family members who are willing to learn and understand better, and I'll admit, also recognize your own demographic as who you are as a professional and how that might be interacting with a particular parent. Um, there are some parents where my own male privilege comes in handy. And sometimes certain parents are more willing to listen to me than another colleague. Uh, there are other parents that might not be willing to listen to me as a result of who I am and who I bring to the clinical relationship. And it's my job to understand and figure that out, and maybe work with getting them to someone who they're going to understand more. So recognize your own self in the clinical relationship, and the power that you have when you're trying to interact with family members who might not be coming at this in the same uh, direction as you.
So we've got a couple more questions. Not sure we'll be able to get to all of them, but I want to bring this one up because I think it's an important point of clarification. When you bring up regret, I wonder what kinds of treatments are youths under 18 getting that are irreversible. My understanding is that hormone therapy is reversible.
Well, I would definitely ask for anybody to go and review all of the existing information about all of the treatments that exist. There are different levels of reversibility and irreversibility depending on certain doses and depending on certain treatments themselves. But there are certain elements of hormone treatment that do have irreversible effects. And I think it's important for you to go and look them up yourselves, because today's talk is not meant to be a description of the different effects of the treatments. It's meant more on a broader viewpoint of know what the treatments are, know what those effects are, ask your clinician, and know what the legalities of those treatments are in the municipality where you're located.
So do we have time for one more?
I'm fine with that. Oh yeah, you were asking me? Yes.
Yeah, yeah, yeah,
I'm
yeah.
watching the chat with
All right.
yeah.
So here's one more. Yeah, well, there was a question about recommended literature with regard to your last answer, and maybe we can
I think that some
um,
again this
one last one for now.
oh, sorry, what were you going to say,
Go
Dr.
ahead. Go ahead. Go ahead.
No, I was just going to say, really, when it comes to the effects of treatments, and when it comes to understanding what's permanent, what's not permanent, this is where it's absolutely crucial that you can develop trust in the doctor you're seeing. If a doctor is telling you that everything is fine and don't you worry about anything, I would question. And if a doctor is telling you everything is harmful and it's all really bad, I would question. It's developing trust with an expert, a knowledgeable person who's been through uh, multiple years of experience as much as possible and understands the long-term effects on these treatments to be able to talk through what are some of the long-term ramifications, what aren't, and help families approach the risk-benefit discussion on an individualized way.
So here there are lots of great questions in the Q&A box and in the chat. Wish we'd get them all, but here's one that comes up so often. Let me just bring this last one to you.
Sure.
One of our parents has a 5-year-old boy that wants to wear dresses and quote girls' clothes, but
Yep.
is afraid the boys will bully him.
Yes.
Any guidance on how to help this family?
Uh, I wish I could give you guidance on how to help the family, but my first response to that question is there's so much more I'd want to know before I can offer guidance. I would want to know about their locate where they're located, what that child's strengths are, how resilient that child is, what feels right for them, who in the family is accepting, what might some of the safety implications be, how long this has been going on. And so really to offer specific guidance would be inappropriate of me, especially after I just gave a big talk on how important this is to really collect and understand and get to know our families in a holistic way before really giving them guidance. And another thing that I should say is I don't believe it's our job fully to direct people what to do or what not to do. It's our jobs to help parents and families by listening to their stories and understanding where they're coming from, help them be able to think about the pros and cons of any decision in a way that they might not have been able to think about before.
Thank you so much, Scott. I am so appreciative of your your care and thoughtfulness, and you're always sort of digging into the nuances and the uniqueness of each child and family. So we've got another 13 minutes for you to take us around the bend.
And honestly, this last section is not that long, so I think we'll have more time for discussion too. So our final section today is future directions and call to action. Um, I'll first say we cannot avoid talking about some of these really important and complex topics. It is absolutely crucial that we be able to address regret, that we be able to address factors impacting someone's detransition or not, or retransition. And there's a whole emerging literature on that that I find to be fascinating. And I'll call out Dr. McKinnon, his work. Kinnan McKinnon from Toronto is a leading international expert on narratives of detransitioners. And I look to him and his work to understand that better. It's important that we understand the role of peer influence. This doesn't mean that gender is contagious. This means that like-minded kids might find solace with other kids going through similar things. And so forms of social connection between like-minded adolescents is a part of normal routine adolescence, but we should understand what drives their desires and their what's right for them and their priorities, not particularly like did they experience a particular identity as a result of going to a different group. Fertility, these are important conversations that we need to be having. Decision making and what makes a healthy decision maker from a less healthy decision maker, as I talked about earlier. The idea of autism and gender is coming up very much, and there is a significant overlap between the two communities. It doesn't mean that if you're autistic, you cannot be trans, which I think we just get so stuck in these either or black or white thinking, but rather there's an entire community of trans autistic individuals who themselves have unique needs in the clinical treatment frame, particularly as, from my perspective, how do they approach their decisions, black or white thinking, and their ability to detect safety in their environment as a result of their neurodiverse identities and presentations. And then family perspectives and being able to mesh together the different family perspectives. And then the role of gatekeeping, which is a common word used to describe providers who are in between a person and the treatment they seek. Personally, my opinion is that the term has a negative connotation because it just sets up the provider to be someone who's kind of waiting at a door with, as a guard, waiting to try to have someone prove to them who they are. Whereas healthy guardrails are an appropriate part of any decision-making treatment frame. I need to obtain consent for a parent or for a young person to start an SSRI. And in some situations, I actually feel like moving forward with an SSRI does harm to a young person when the bulk of what's causing their depression could better be served in a therapy setting. So there's different perspectives in the matter, and we have to be able to define what this means and disentangle it. It's a tough time out there politically. I left my position. I left academia because I feel like I can make a better difference doing talks like this and reaching parents and families out there who are struggling with how to protect their young person's identity exploration in a time of such political uncertainty and polarization. So here's what I say we can do. We can educate on the validity of trans identities. Give grace to those struggling to understand, but not in a patronizing way, in a way that really meets them where they're at and validates that they are allowed to be confused. They are allowed to question whether this is the right decision for their young person or not. Understand the importance of developing gender literacy, both in yourself and the young person that you're working with. Gender literacy is something that people need. If we could all become more gender literate people, then I think that would save a lot of us a lot of heartache, and that's an important goal that we can do regardless of what bans exist and what bans don't exist. Recognize the complexity of the human experience and that gender can serve different functions for different people and different families. It's not one homogenous group. But probably one of the biggest pieces of advice I could give is to focus this effort on patient autonomy and shared decision making in healthcare instead of the reinforcement of victimhood. Bans that take away shared decision making between doctors, therapists, experts, and families are extremely dangerous. And if they are happening in this particular field, they can happen in another field. And this precedent cannot be set. And therefore, the goal is to really not take on victimhood because that's what this is designed to do. It is one thing to be victimized, it's another to become the victim. But when we allow our young people to become victims when they are being victimized, we're perpetuating a cycle, and that we're also not fostering healthy development and the ability to develop gender literacy. And if all else fails, say what Taylor Swift would say and just tell everybody you need to calm down. And this is me at the Eras Tour. She's a personal hero to me, and this song really inspires me. So the last thought is to remember the concept that I call an equalizer concept, meaning in order to know if you can be effective with someone who is having a conversation about gender issues, these are the main issues that you first need to agree on. You need to be able to agree that gender identity is a real and valid concept, that it's distinct from an assigned sex. Variations in alignment between the two are not inherently rooted in delusion, and often correcting this alignment with evidence-based medicine can improve people's lives. And so I'm grateful to all of the people at Brazelton Touchpoints for giving me this really unbelievable platform. I will be at some point, I'm not ready yet, but I will be seeing parents for consultation, not treatment. and should I have a new website up and running should people feel that they'd be interested in a form of a consultation with parents. Again, thank you so much for this wonderful opportunity, and I'm happy to have a moment for reflection.
Thank you so much, Scott. I feel tremendously honored to be in your presence, in part because you were so thoughtful and you've listened so carefully to so many children and families, that you have this really profound understanding of the enormous range of variation from one individual um, child, youth, family to another, and your discipline to always be cautiously and calmly parsing out what's really going on for each one of them, but also because you're incredibly brave in the day and age that we're in. It takes a lot of courage to um, talk about this topic at all. Although, if folks could listen, I think they might recognize how much there is to learn. So before you go, I just wanted to ask you about safety. There was one comment that made me think about that. It goes, in an age of national registries, it is scary to discuss the relationship between gender and neurodivergence, although it's an important conversation. And you may or may not want to address that specifically, but I know you get death threats, so I thought maybe you could tell us what your recommendations are for balancing the courage to stand up and speak out with taking care of yourself and protecting yourself.
That's a good question. Um, it's not in my nature to be an outspoken person who is seeking the limelight on all of these issues. In fact, I would consider myself someone that would just rather go do my work and help the people I've helped and move on. And the sad part is that, like, I know that I have a very unique perspective given the amount of clinical experience that I've had in three different systems that show how models of care can impact patient care delivery, and that really this is about how to provide the care, not whether to provide the care. And so I do recognize my privilege in that I hopefully can use this platform as the person I am to make a difference. If someone else were to have just said the exact same words that I just said, whether they be an ethnic or racial minority, or whether they not have nearly as much clinical experience as I, they would be immediately dismissed. Some might dismiss what I'm saying already, regardless of my clinical experiences, as I've encountered. But I feel like these families that I've worked with deserve someone to go out and be able to share their experience, and that is what I'm here to do, because they are forced to either have to come forward themselves and put their own privacy and safety on the line for their kids, or stay silent and not have the world hear what their experience is and therefore not be educated. And so the, I'm putting that at the center of my next part, my transition with my journey into outside of academia and into something that's maybe hopefully able to help get through some really challenging times. My self-care is through my piano playing. So that I would say is I, I I take lessons, and I'm really trying to um, flourish in my piano playing. And LinkedIn is a place that I have been much more active lately, and I would urge people to connect with me on LinkedIn. I even have one of my piano playing up there, but more so to get my thoughts on the nuance and the complexity and the balanced, reasonable, logical approaches to a complex topic that everybody else seems to be turning into a culture war.
Well, you'll have to come back, Scott, and play the piano for us. But let me thank you now for, I think I've heard you play actually, but for Tyler Clementi, a fundraiser actually. But
Oh,
um,
yeah. Oh, wow.
yes, but for now, Thank you so much for today's really illuminating conversation, for your work, for the balance, nuance, and hope you bring. Thank you for your leadership, for your courage, and for your vision. And for all of you who have joined us today, thank you for being with us and for all you do. And please do come back this fall for more Learning to Listen conversations for change.
Thank you.